the national mission to build an NHS fit for the future, because we recognise the problem, but more than that, we are understanding that we must be proactive in tackling it. Only by doing this will we genuinely build a better, fairer, more equal country. It's a pleasure to be here for what is billed as the keynote speech. I'm not sure whether that's a sop to me for getting the graveyard slot or a sop to you for staying for the graveyard slot, but whichever it is, it's my pleasure to be here speaking at this integrated care seminar. For those of you that don't know who I am, I'm Andrew Gwynne. I'm Labour's Shadow Public Health Minister, and I'm also the Member of Parliament for Denton and Reddish, which isn't too far from here, partly in Tameside, partly in Stockport in Greater Manchester. Now, tackling health inequalities has been a personal mission for mine for years. In fact, it's one of the reasons why I got into politics in the first place, because I grew up in Denton, the seat that I now represent, and have always lived in that town. And for those of you that don't know Denton, it's not a great big place. It's got a population of 38,000 people. It's got a geographical space of about 2 miles across and 1.5 miles in length, and is divided into 3 council wards. And as I say, I grew up in Denton, and I lived in the Denton West ward, which is one of the more prosperous wards in Tameside. And my best friend, who was in the same class as me at school, we had the same interests, we did the same things, we hung around in the same town. He lived in the Denton South ward, which is one of the poorest wards in Tameside. We lived no more than a mile max apart from each other. And yet on average, he will live 10 years less than I will live. And for me, that is a burning social injustice. It cannot be acceptable that 2 kids from the same town, in the same class, will have a decade's life expectancy difference. And it's something that I've always felt incredibly passionate about. Because my friend didn't lead a particularly dangerous life. He wasn't a daredevil. He was just like me. Pretty ordinary, active young kid from Denton. What I didn't know back then was the wider determinants of health. The things that in your environment that contribute to your health outcomes. And these include, but they're not limited to, your access to affordable food, your access to green spaces, the amount of money you earn, your genetics, your education, whether your parents smoke, even the sector you work in. There is a reason that deprivation is intricately linked to your health. And it's not because poorer people choose to lead unhealthy lives. Instead, this complex web of determinants bears down on the individual and causes general health within deprived communities to worsen. Sir Michael Marmot was the pioneer of work in this space, and he's had a tremendous influence on my own thinking, both as Shadow Public Health Minister, but more generally as a politician representing a community and a constituency with such stark differences in life expectancy. Now, I think if you ask most people in the country a simple question: should where you live and where you were born influence how long or how well you live? And I think the answer would be a resounding no. It is incumbent, I think, on policymakers and on health leaders to tackle this problem head on. Doing so shouldn't just be a moral imperative, but a practical one too. Our NHS, as we know, is under extreme pressure, not just from the effects of COVID, but from many of the social determinants of health. Things like obesity, malnutrition, smoking, and alcohol harm profoundly damage productivity and economic growth. If we truly want to build a prosperous country, then we need to get serious about tackling health inequalities. So what should we do to address this problem? Well, firstly, I believe there needs to be a culture shift in how we view public health within politics. Too many people still view health, and particularly public health, exclusively through the lens of personal choice. You want to be healthy? Be healthy. This isn't an argument that washes with me. If it worked, then we would not be facing some of the highest obesity rates in Europe and watching health inequalities widen. Yes, personal choice is important, but it is by no means the key to unlocking this problem. Instead, we have to look at things holistically and cross-departmentally. How can we improve access to good food and education? How do we guarantee decent housing and well-paid work? Those are the questions that we should be grappling with. The problem is a big one, but the principle underpinning the solution is not. It's about prevention. Preventing people getting sick, preventing them from dying younger, preventing them from developing health complications. Departmental integration is an essential part of tackling these problems. And last year, my leader, Keir Starmer, said that the next Labour government would, and I quote, expect the Treasury to weigh every pound it spends, not just for its effect on national income, but also its effect on national well-being. This is music to my ears if we can make it happen, because I think that is a vital, crucial principle, because the problems I've already outlined are so broad that all the levers for making a difference do not necessarily lie within the purview of the Department for Health and Social Care. Indeed, you could even argue it doesn't necessarily lie in the purview of national government, but it is multifaceted across national and local government, across industry and business, across departments and organisations. We therefore need buy-in in central government from every department to make a difference, and the same is true in local government and neighbourhoods too. Take free breakfast clubs as an example, which Labour recently committed to. This was a decision taken by the Shadow Secretary of State for Education, but which will make a world of a difference to the health and well-being outcomes of young people across the country. Another is our pledge to instruct the Low Pay Commission to link the national minimum wage to the cost of living. Again, this will have huge health benefits, ensuring that more people have money in their pocket to afford decent food and to heat their homes. For too long, prevention has been viewed by government as too difficult, and therefore it's often been overlooked. The strategy that's been employed is a bit of a whack-a-mole one, where we're reacting to the symptoms of a problem rather than to the root causes. And I want to change that. And this is a vision shared by my boss, Wes Streeting. You will have heard us talking about the need to reform the NHS, to make it fit for the future, for the 21st century. And prevention is underpinning these calls for reform. Take primary care as an example. People can't be seen by a GP and therefore are presenting to A&E with acute health problems that are expensive to treat and that could have been prevented. We cannot continue on this trajectory. We must embed community interventions, empower pharmacies, embrace new technology, and increase the number of health visitors in local areas. All of this will unlock the front door to primary care and therefore get people seen before a problem becomes a crisis worthy of an A&E visit. But this will also have to come alongside a focus on addressing the crisis in social care. And we've been clear that the first step to doing this will be to drive up staff retention and recruitment. This means giving care staff the terms, the pay, the training and the conditions that they deserve. Reform like this is not an anathema to the NHS, it's imperative to its survival. We must also get proactive about tackling the wider determinants of health head on, be bold in our policy making. Now, I've been a Member of Parliament for a long time now. I was first elected in 2005, 18 years ago. I was in the Commons when Labour passed its indoor smoking ban. Believe me, this was not an easy fight to have. In fact, I almost got myself barred from Denton Labour Club on a permanent basis when we included private clubs within the remit of that act. But it has transformed public health in this country, along with other measures that have followed in tackling smoking. In a similar vein, the next Labour government cannot and will not shy away from taking the brave steps needed to improve public health. We are currently considering and consulting on all of Javed Khan's Smoke-Free 2030 review recommendations. And with regards to obesity, we're consulting on various regulatory interventions so that if we fail to see sufficient action from government and industry, we will take the action that's needed. Now, as we are in Manchester and at a regional seminar, I think it's important to talk a little bit about the excellent work that's going on within our regions. Back in 2020, Manchester became the first Marmot City region, something I am incredibly proud of, and it's published an exceptional piece of work in the form of the Building Back Fairer framework, which will inform public health strategy until 2027. 8 themes have been highlighted, including improving housing, the environment, prevention, and other key determinants. Crucially, the report also contains an action plan about how each of these themes will be addressed. Under the theme, Preventing Illness and Early Death, the strategy sets out an approach to embed public health and to enable networks of GPs and other neighbourhood services to work more closely together, using data and local insight to improve health outcomes for specific communities. I think this work has the potential to be truly transformational, and local authorities, city regions, and national government could learn an awful lot from it. We must get better at building networks between services so that the left hand knows what the right hand is doing. This strategy is one, I believe, that recognises the need for the integration of services and recognises the complex causes of health inequalities. I want the next Labour government to learn from the city regions doing great work. We have made tackling health inequalities a key component of our national mission, one of those 5 missions that Keir has set out, the national mission to build an NHS fit for the future. Because we recognise the problem, but more than that, we are understanding that we must be proactive in tackling it. Only by doing this will we genuinely build a better, fairer, more equal country, a Britain that is happier, healthier and more prosperous. And I believe we've got a lot to look here at Greater Manchester for what we can do when we get into government. Thank you very much.
I'm going to put the first questions to the floor.
Okay, so my name is Karen Rye. My question is about culture, because we talked a lot about that today. And let's just be completely honest. I think the NHS is on its knees. I don't think it needs improvement. It's just completely crashed and crumbled. And what we hear is of nurses and doctors leaving every single day. So today we heard Professor Wardley talk about how junior doctors don't want to go into the system. Yeah. And we've talked about doctors leaving because of the NHS pension situation. But we have other doctors and nurses that are also leaving. And those are those honourable doctors and nurses who are whistleblowing. And I bring to the table more regional cases like the Christie whistleblowers. And these are doctors and nurses who have highlighted issues within the system as a means to support the system, but then they are shunned out. So my question to yourself is, what is it that you're doing to address the cultural problem? Because that cultural problem now is having an impact on the patient services that you offer, the opportunities. And what's more disheartening than anything is that those doctors and nurses who have raised valid concerns, they go off into international waters to rebuild systems that are outside of the UK. Yep. So that's my question.
No, that's a very good question. I'll separate it into 2 issues because there are 2 interlocking issues within that. Firstly, in terms of staffing in the NHS, we recognise the enormous pressure that the NHS is under. And that's why we have been arguing. And it looks like the government might be moving on this. And we've said, pinch our plans, please do. But there needs to be a proper workforce plan, a proper strategy for getting people into the NHS. And we've been very clear, we would scrap the non-dom tax status and use half of that money to pay for the largest expansion of NHS workforce in the history of the health service, to increase massively the numbers of doctors, nurses, care workers and community healthcare workers. And we would increase the number of medical school places paid for by that. That is absolutely crucial going forwards, as are some of the terms and conditions, including the pensions. We do have an issue with the government's approach announced in the budget, but we've said we would have had a bespoke deal for the healthcare profession to try and keep those doctors in the profession that are leaving because of the pensions. And that's possible because we did it for judges as well. You don't have to extend it for everybody who's a very high earner. So we recognise that the workforce concerns are a crucial part of the problem and part of the solution as well. On your fundamental point about the culture of whistleblowing, it cannot be acceptable that NHS staff doing the right thing, highlighting failings, are then persecuted, punished, and worse, are lost to the system. So we've got to get much better in having a zero-tolerance approach to failure within parts of the NHS, and to actually protect whistleblowers that highlight where there are severe deficiencies, because that's the only way we're going to get that better NHS. And I want to see greater protections for whistleblowers, because those that do make that brave decision to stick the head above the parapet are actually part of positive changes in the health care system. They're not part of the problem.
Thank you, Andrew. Interesting, and I know you used the word whistleblowers because it was part of the question. Maybe we actually need to change the language, right? You know, maybe we need to call them something sexier than doing the right thingers, but doing the right thingers, yeah? I'd like to invite some more questions from the floor, if I may. Yes, gentleman over there, would you come up to the front? Thank you.
Hi, I'm Ryan Reid from SPS. Today we've heard a lot about the challenges, particularly just in the last question, faced by the NHS, and a lot about the need for reform. You mentioned yourself and the need for change. And you know, fortunately today there's also been some positive discussion about great things going on and the brilliant changes that can occur. So my question to you is, obviously this needs big transformation, and how would you embed and build a transformational culture in the NHS which is understandably risk averse?
And again, that's a really good question. And this is something that the Shadow Health team have been grappling with, because whilst we've managed to get some money out of Rachel Reeves, which is no mean feat in the form of the extra investment for the workforce, we recognise that we can't just be putting ever more money into a system that actually needs to move with the times, needs that reform, and we need to get better outcomes for patients in a whole variety of areas. One of the first things that we've obviously prioritised is getting those waiting times and waiting lists down. That's absolutely fundamental right now, and part of the way we do that is how I discussed in my speech, by fixing the front door, the primary care system. You've also got to fix the back door, the social care system as well, because otherwise you don't get that free flow through hospitals. But also we've got to have that mind shift that a lot of things that traditionally have been done in hospitals don't need to be done there. They can still be done by the hospital trust. It's not about taking income and money away from that part of the healthcare system, but they can be done much closer to where people need it to be done, and often that's in somebody's house, or at least in the community where they live. So we are looking at that kind of reform, but we're also looking at how we embed some of the technological advances that there have been, because Britain is at the cutting edge of a whole range of medical and technological advances, and yet the NHS is really slow to pick that up. And some of it can be really simple stuff that we now take for granted because of the pandemic. You know, before the pandemic, a lot of people would have thought you were absolutely mad to have things like Zoom meetings and Teams meetings and so on. Now it's part and parcel of what we do. In fact, there's a load of people watching me speaking now through live streaming, and that's great. But there are huge healthcare advances as well as a consequence of that. And I'm going to use an example, and it was from before the pandemic, in my own local patch, because I know it so well. And some of you might have heard this already, but at Tameside Hospital, which was a Keogh Review Trust hospital, it was really struggling to provide quality healthcare, which is why it was put into special measures. One of the issues, and some of it was a bit of a legacy from the Shipman era, was that too many very elderly, vulnerable patients who were in care homes, when they became sick, the automatic reaction of the care home was to get them in an ambulance and dump them at A&E at Tameside Hospital. And of course, you know that for very sick elderly people, often they don't leave hospital alive as a consequence of that. And that did have some impact on Tameside Hospital's mortality figures. One of the measures that the new chief executive brought in was better use of teleconferencing. And they employed somebody, I assume he's called Pete because everybody knows him as Digital Pete, and he's got a Twitter account as well. And he made it his mission to get every single care home in Tameside and Glossop connected to his hub at Tameside Hospital, so that if an elderly person is sick, rather than the default being you put them in an ambulance and you take them to A&E, the default is you contact Digital Pete. Digital Pete will then triage it, the case. If a doctor or a nurse needs to come and give an opinion, they will. most of the cases can be dealt with online sufficiently. If they need a doctor to go out to the care home, that's now what happens rather than the patient coming to the hospital. And only in extreme circumstances where hospital is totally the most appropriate journey for that patient to take, do you get an ambulance bringing them. That has transformed patient care for those most vulnerable elderly patients in Tameside. And it's made a big difference to healthcare outcomes in the borough at that age range too. That's just a simple thing using something that we now all take as standard, Zoom or Teams. But before the pandemic, it was revolutionary. An example of how we can utilise technology for better healthcare outcomes as well.
Okay, thank you, Andrew. Great answer and great use case as well. Any more questions from the floor? Yeah, gentleman in the pink shirt and Ros.
Hi, Andrew. Martin Dean, CDXO for SCC, so digital transformation in healthcare is what we do all the time. One thing I see frequently speaking to ICS leaders up and down the country is not just a resource question or a capability question, but a mechanism and process question around funding. Yeah. If we want to look at integration, if we want to look at advances in technology, people need to be able to behave the right way to adopt it. If people are effectively paying for things through CapEx and not through revenue, they can't engage with the marketplace in the right way. I see lots of discussion on funding. I see very little nuanced conversation about the mechanisms to adopt and maintain a quality of care. What is your stance and your approach?
So again, this is something that I've been thinking a lot about when I've been meeting people from that sector of industry. They've made very similar points. And I think this is something that very early on, we need to work with the sector to come up with how we are able to roll out some of these technological advances that we want to see in the NHS and how we facilitate that both in terms of funding mechanisms but also the delivery mechanisms. Look, the government is not great, and this isn't a party political point because no government is great at rolling out big IT projects. Actually, I think we're best to leave it to the experts. So if we can say from ICBs that this local area wants to transform a particular service and there is some form of technological answer to that, how do we facilitate the conversation with the local NHS in that area, with the Department for Health and Social Care, and with industry leads to be able to get that right first time round and not costing multi-billion pounds to go up in smoke because it doesn't work and it wasn't fit for purpose. So I'd be very, very keen to work with industry to get these mechanisms right early on in a Labour government so we don't make a mess of it.
Hi, I'm Rosway. I'm the Director for National NHS Engagement with IQVIA. I guess it's quite a broad question, but we know that the NHS is in crisis, the healthcare system is in crisis, and that's the responsibility of a huge amount of organisations and people. And we've heard a lot today about the sheer scale of people and organisations that contribute to healthcare systems. So given that we're in a low situation with healthcare, how bold can we go in terms of achieving the aims that everyone is talking about? And what could or should the government, any government, what should they be doing to make sure we can achieve the ambitions that everyone is really talking about and have been doing for a long time? Yeah. These aren't new conversations. Yeah. What can be done to help us meet those bold ambitions? Yeah.
Now that is an excellent question because it allows me to get off my chest some of my own frustrations, because where this debate has gone, inevitably, is we're almost in a cycle of doom and gloom, that the problems facing the NHS are so huge, so insurmountable, that we're never going to be able to fix them. And for some, that is very convenient because they have a different view on how healthcare should be provided in this country. But for those of us that believe in a publicly accessible, free at the point of need healthcare system, actually the challenge is ours to convince people that it doesn't have to be this way, and that there isn't an impending sense of doom when it comes to the future of the NHS. And in part, that is setting out that long-term vision that we want to tackle some of those endemic health inequalities, and that means a real focus on prevention, and it has to be cross-departmental. It also means sorting out some of the short-term issues, like the staffing crisis, and ensuring that we get those reforms in as the quid pro quo for that massive levelling up of staff across the health and care system. But also, it's about reminding people that we can make a difference through investment, through reform, and through the political will to change things for the better, not just from politicians, but also from sector leaders and from clinicians and from staff right the way through the organisation, having that focus on quality, having that focus on better patient outcomes, having that focus on delivering for their communities. And I always say, look, in 1997, the NHS was on its knees. It absolutely was. It's probably in a more precarious condition now than it was in 1997, but there are parallels. And it was through political choices. It was through record investment. It was through a reform programme that meant that the NHS that we inherited in 1997, with record waiting times, record waiting lists, a hospital estate that was crumbling, staff that were demoralised and undervalued. We ended up in 2010, and 2010 isn't where I want to go back to. It was an improved health service, but it still had issues. It still had problems. It still had challenges that we needed to tackle. It wasn't perfect, but we had the highest waiting list, the lowest waiting list, the highest patient satisfaction, the lowest waiting times. It was independently judged by the Commonwealth Fund for being one of the best healthcare systems. I think it was graded at number 2 in the Western world. Things that we can be proud of. And if we did it then with the political will, with the investment and with the reform agenda, we can do it with the goodwill of the staff and the leaders in the sector. We can do it again.
No, you talk about the then. You actually had an economy to come back into.
Yes.
Which was helpful because Blair, of course, brought spending on health up to the European
level.
average
Yeah.
by, I think it was 2007. We're in a very different situation now. But that actually links to the question that I want to finish with, and that's about Labour's position on the role of life sciences as part of the solution. We know Wes has done a lot of work talking to life sciences industry that, we're not going to do the Corbyn and we're not coming to privatise you, which was always bonkers anyway because we're a global industry, so that was never going to happen. But what do you see, and can you give a commitment about the role of life sciences as being part of the solutions, like we've heard today, bringing solutions, working in partnership with ICSs, making investments, and addressing a lot of the upstream problems? So what do you see as the role of life sciences going forward? And let's not forget, the life sciences sector is the UK's most productive sector. Yeah. And might I say one other thing? Rachel Reeves, Wes Streeting, we're the 3rd largest employer in the UK. I've been trying to get to see those dudes for the last 6 months, and they're too busy.
Right, well, on that last point, let me see if I can open the door for you and make it my problem. But actually, I think this is a really exciting place for us to be, because the life sciences sector, as you say, Britain is a global leader in it. And that is something that we should be proud of. We can grow that sector further, and that's best not just for the NHS. It's also great for UK PLC and the economy more generally, because these are high skill, high tech, and considerably high wage jobs that I think we can really grow. And I think there's looking at it parochially, there is a huge opportunity here in Greater Manchester and in the Northwest to grow the life sciences sector still further than it already is. look, it is obviously part of the solution here, not only because these are the innovative drugs of tomorrow that are being developed, and often these will be life-saving and life-changing. We've also got to make sure that they are accessible to the NHS, and you do that in partnership. You know, it's a very simplistic answer to say, well, we'll just nationalise you, and therefore we can cream off a certain proportion for the NHS, and then we'll sell the rest to the world, make a load of profit, and then reinvest it into the pharmaceutical industry. That doesn't work for all the reasons you've said. It's a global industry, and all that would happen is you'd up and leave the United Kingdom, and we'd lose those jobs, we'd lose that innovation, and we would lose being at the cutting edge of some of these new drugs and treatments that are being delivered. I want to see us work in partnership. I want there to be a good quid pro quo for the NHS. And when I've spoken to people working in the life sciences sector, they're very keen on reaching that kind of accommodation, that we grow this industry, we grow your profits as a consequence of growing this industry, we create new jobs in this country that are very much the kind of jobs we want to see. And that includes ensuring that we train up the next generation of scientists and mathematicians and computer experts to be able to develop where we're going in a whole range of exciting fields in the life sciences sector. But also that by doing that, the NHS is at the front of the queue for these treatments, these new drugs. And I think it's incredibly exciting if we work together on this.
Excellent. Thank you. I think that was Marie-Andre from who's the president at Novartis, is sitting right behind you. So I think that was a really exciting and optimistic answer. And we're not just talking about drugs. We spent all afternoon talking about what we call beyond the pill.
Yep.
So services that we will bring that will improve the patient pathway, improve the patient's journey, improve the outcomes. And just a little figure to take home, which I said at the beginning, it takes on average for a NICE approved technology 4 years and 2 months to be adopted locally.
Which
That's
isn't
a
good
massive
enough.
challenge.
It's not
so
good
Dobson
enough.
brought in NICE, fantastic, great. Iron out postcode inequalities. The postcode inequalities are not ironed out.
No.
So that's one to take away. So I am going to wrap this session up. Ben is going to come and just give the final words. Really, Andrew, thank you. I think that was very passionate. So can we thank Andrew for his commitment today?